Hey Sam, how you doing, bud?
Oh, hey.
Cool. Hey Sam, I want to talk about the dose trial since it's something we use every day. The dose trial from 2011. Do you remember the clinical question the study aimed to address?
Oh, yeah. The study focused on comparing continuous versus intermittent diuretic infusions. So basically, two strategies, but also low versus high dose in patients with heart failure. They wanted to also see how different strategies impacted symptom improvement and renal function. All right. So I have a question for you.
Mhm.
What's the bottom line of the study?
That's a good point, Sam. If I remember correctly, the point was that high dose loop diuretics resulted in better improvement in symptoms compared to low dose diuretics. So like the dose made the difference. And although obviously it came with some risk of renal impairment, and it interestingly found continuous diuretic infusions did not show any additional benefit over intermittent boluses. So like doing something like Q4 versus like a GGT drip would not make a big difference, or it didn't impact renal and function impairment. So I guess saying all this, what do you think are the major points from the study, Sam?
Yeah, it's like you said, like boluses are the way to go. Continuous drips may not have a role, and ideal dosage is still being titrated, except we prefer high doses. We'll go more into that later. So, how was the trial designed, Uzi?
That's a good point, Sam. If I remember correctly, it's like a multi-center randomized double-blind 2x2 functional factorial trial with like about maybe 300 S patients that finally got included in. And like we talked about, to follow the previous methodology, intermediate versus continuous infusion, low dose and high dose infusion. It took like across 26 centers across the US and Canada for a total of 60 days. So which is like super rare, I feel like for a trial to like have that many patients across this many centers really speaks to its external validity. I guess, looking at this trial overall, what do you think were the key findings here, Sam, in regarding the treatment arm specifically?
Yeah, so we brought it up already and hammered it to the death, but they're out. So they looked at 72 hours. That was the time point that they looked at, and that's how they decided which strategy was best. So high dose and intermittent. And this did lead to greater increase in creatinine levels, but at 60 days, it did not translate into higher renal failure rates. And high dose therapy actually tended to reduce hospitalization rates. So overall, high dose intermittent, and even with the transient bump in creatinine function, overall, it's beneficial and reduces hospitalization rates. What other criticisms or limitations do you think the study has?
That's a good point, bud. And like, I think repetition will make us key here. So just repeating those points over and over again, but also being aware of the criticism. One of the major one was that global symptom assessment might have been too subjective to detect small differences, and then more objective outcomes like the proportion free of congestion, weight loss, fluid loss, favored high dose therapy. Also, which generally makes sense already to begin with, that just was like it's designed to get that result. And obviously, I heard there was a concern that the increased use of thiazides in the low dose group could have influenced the results, as thiazides associate more renal dysfunction and electrolyte imbalances. I guess, talking overall, like we talked about, the study's findings line with current guidelines by the current AHA guidelines. We're talking about how significant volume, I mean fluid/volume overload should be treated with IV loop diuretics promptly. And if they're already on a chronic level, then that initial dose should be equal to exceed their home dose. You don't want to go with baby steps. You want to hit them hard. You want to hit them fast, basically. It's reasonable then to even increase the second dose or the first dose, like a thiazide if necessary. And then low dose dopamine was also to be considered to improve diuresis slash preserve kidney function, but it's not universally recommended when you look at other larger studies. So could you summarize? So actually, let me summarize since you have written it already. That the dose trial, like we've mentioned so many times, high dose diuretics are the way to go. Yeah, you see a tiny bump of creatinine level, but it doesn't actually cause renal failure at 60 days. And continuous infusion surprisingly did not form an extra benefit. And obviously, no matter what we talk about, treatments should always be personalized to patient response and condition.
Yeah, that's good. You've brought up something that we didn't bring up before, which is that you want to look at objective outcomes every day. So strict I's and O's, daily weights, monitor their fluid intake, and then see it improve over time. And these are all consistent with the AHA and ACC guidelines, where people with any of these symptoms, you should give IV loop diuretics and you should give a high dose. We'll go more into that later. And it's reasonable to add additional diuretics like thiazides as needed. All right. So,
Yeah. So sorry, but didn't mean to cut you off there. But obviously, this trial is so influential, and the 80-40-20 rule applies. 80 PO furosemide is equal to 40 IV furosemide, which is equivalent to 20 mg oral torsemide and 1 mg butamide.
yeah, bumetanide.
You better, wow, I butchered that.
Yeah. So for people with decreased renal function like chronic kidney disease, we often need higher doses of IV furosemide to achieve effective diuresis. What's your approach when you're unsure of the home dose?
Well, if I'm unsure of the home dose, I'd go ahead and use this like old rule that was 20 to 30 times the creatinine level. That's typically because the drug needs to reach the nephron to be effective, and with low GFR, high dose might be necessary. It's a strategy that essentially helps patients who are what we call diuretic naive. So we can also that means we can also use this for people who we think have never had loop diuretics or haven't been taking their loop diuretics, so we don't know what their effectiveness is.
Wow, Huzi, you're full of all these tricks, old tricks. How long have you been practicing? But anyways, when we talk about loop diuretics, they work by inhibiting the sodium potassium chloride transporter in the ascending loop of Henle. This helps with effective decongestion through sodium excretion in the urine.
Yep, that's correct. But for most patients, furosemide, torsemide, metanide are more common choices. Furosemide super cheap, duration's about 6 hours. Oral viability varies greatly, anywhere from 10 to 90. Torsemide, butanamide tend to be a little bit more predictable, which are advantages upon discharge, but obviously cost a little more. And that ultimately there was also the transform HF study comparing torsemide and furosemide. It didn't show any difference between in the mortality or quality of life in inpatient settings, did it?
Oh yeah, no. So once you start IV furosemide, the two main things you to monitor are urine output and effectiveness of the diuretic. So after you give the furosemide, check back in an hour or two. If the urine output isn't improving or the IV dose isn't working, you may need to double the dose. Just repeating 40 milligrams isn't enough. Doubling the dose is appropriate.
So that makes sense. And then obviously at the same time, Sam, you want to think about a target body volume balance. So like with strict isonosals, you want the body to aim to be 2 to 3 liters negative. If the pay is if 2 to 3 liters negative is what we aim for if the patient's condition is improving. It's crucial to monitor them, like we mentioned. And then, approximately, like, let's say if the patient after 6 hours only produced 800 mils of urine, and the with the first 500 mils being the initial 2 hours, what do you do next?
Oh, well, you check for symptom improvement. Check how well they're saturating on their oxygen. If oxygen still is low or edema persists, then you consider adjustments. I think the rule I'm noticing is that if it's not working, you just keep going up. But then
Mhm.
what happens if you keep going up and you see a rise in creatinine?
Good point, bud. So I always think of creatinine as a sign of kidney function, but you have to keep an eye on it. So an increase in creatinine can always result from aggressive diuresis. Think about it, you're putting more pressure on the kidney or even volume depletion. But if creatinine rises, uh, it typically correlates to volume depletion. If you so you can always pause the diuretics briefly, but obviously if the patient remains volume overload, you can continue with the diuresis. I guess, thinking about this, what do you think about inotropic therapy?
Yeah, I guess if people with heart failure and then you're diuresing them, getting rid of all this fluid, um, they can have poor cardiac index, and then it can cause poor kidney perfusion as well. So that's when you have to start thinking about inotropic therapy to improve cardiac output and renal perfusion. This is relevant if the diuretics aren't reaching the kidneys effectively. So actually improving cardiac output can allow the diuretics to reach the kidneys more easily. How do we handle diuretic resistance?
That's a good one, bud. The diuretic resistance, you want to consider sequential nephron blockade. This involves using thiazide diuretics like metolazone, sorry, I butchered that, and chlorothiazone alongside the groups. This strategy helps block sodium reabsorption at different nephron sites. Uh, so I guess you can think about this as combining other diuretics. And when you think about combining other diuretics, you can also add on acetazolamide, which is a carbonic and hydrase inhibitor. Sorry guys, butchering these, which further blocks some of the sodium reabsorption in the proximal tube, and spironolactone, which works in the collecting ducts.
Sounds like you're throwing a lot of diuretics. Like, won't you cause massive electrolyte imbalances with what you're doing?
That's a good point, man. So you got to keep on top of them, like especially in mag and potassium. Diuretics can shift these levels, whether intracellular or extraurinary. So you want to use potassium chloride if hypokalemia occurs, and be cautious with thiazides as they can cause hyponatremia. Adjust treatment based on electrolyte levels and overall patient status.
Wow, great discussion. I learned a lot from you.
Thanks, but I really felt like I was learning from you. So the and obviously, but as always goes, always tailor the approach to the individual patient's needs and responses.
All right.